Now, in the fifth and final section, we will talk about the treatment options available for the chronic meningitis. We will talk about approach to the enigmatic patient. Then we will talk about empirical therapy for chronic meningitis and then the treatment for immunocompromised patient. Approach to enigmatic case determined by extent of clinical deficit, rate of progression. So patients in which the diagnosis is difficult and it's hard to find out what's the cause of the illness, then we should look for the clinical deficit, how much is the extent of the clinical deficit, and what's the rate of progression of the illness. If asymptomatic or mild symptoms are present, wait until cultures are finalized. Waiting for the culture again is important, so we should start with the specific therapy. Then we know what's the causative organism which is involved, and then the treatment is started accordingly. So in case patient is not very serious and asymptomatic or mild symptoms, we can wait for the result of the cultures and we should do that. Ventricular peritoneal shunts to relieve hydrocephalus, risk of disseminating undiagnosed inflammatory process into abdomen. So if there is hydrocephalus, we perform ventricular peritoneal shunts to drain the excess hydrocephalus, and in that case usually there is risk of transferring or disseminating the illness in case if it's undiagnosed to the abdomen. So that's the enlarged ventricle as a result of hydrocephalus due to increased cerebrospinal fluid. This is the underneath skin. That's the shunt to relieve the hydrocephalus. So this is the approach to the enigmatic case. Mainly we should wait for the culture to come, the result of the culture to come. So we should start with the specific antimicrobial therapy, but this is important only in case if the patient is asymptomatic or if they have mild symptoms. If not, then usually the treatment is started to relieve the symptoms of the patient, and then once the result of the culture arrive, then we can start the specific therapy. And another important point is that it can cause dissemination of the infection to the abdomen if the shunt is created between the ventricular peritoneal shunt is created for the treatment of the hydrocephalus. Now the empirical treatment is antimycobacterial agents. Antimycobacterial agents are available for different microorganisms that can cause chronic meningitis, and sometimes just the broad spectrum antimycobacterial therapy can be started or initiated that covers the most of the microorganisms that can be involved unless we can get the cultures. In case of the fungal infections, amphotericin B is the treatment of choice for different fungal infections. Glucocorticoid is the important drug used for the non-infectious inflammatory causes of chronic meningitis. So for infectious causes, we have antimycobacterial therapy, which can be given antifungal drugs for fungal infection, antibacterial or antibiotics for the bacterial infection. Then we have antiviral drugs available, antiprotozoal and antihelminthic all these drugs can be tried for the infections. But in case of non-infectious causes, we talked about so many different non-infectious causes which can be associated with malignancy, and then we have chemical compounds, different systemic diseases, different causes. In that case, glucocorticoid is the treatment of choice for non-infectious inflammatory causes. Then again, it's important glucocorticoid for lymphocytic meningitis of tuberculosis. If tuberculosis is the cause of meningitis, mycobacterium is associated. Glucocorticoids are also effective against that type of chronic meningitis. If it is associated with low cerebrospinal fluid glucose, sixth and other cranial nerve palsies. Sixth cranial nerve and other cranial nerve palsies are present in patients who have chronic meningitis, especially the intracerebral chronic meningitis. We already talked that different cranial nerves are associated with that type of meningitis. So sixth and other cranial nerve palsies. Now the glucocorticoid is the treatment of the choice for the non-infectious inflammatory processes. And for patients on prolonged anti-tumor necrosis factor therapy who develop chronic meningitis, glucocorticoid is also effective against those patients. Then most useful empirical therapy now we know is the glucocorticoid, especially in patients who have non-infectious inflammatory processes. In the immunocompromised patients who have illnesses which lowers the immunity, who are on chemotherapy, and who have cancers, different malignancies, infections like AIDS, HIV virus infections, they all are immunocompromised patients. And these patients, the cause of, usually they have pleocytosis present, then mild meningeal signs at onset of HIV infection. HIV patients are also immunocompromised patients. Low-grade meningitis persists. Toxoplasmosis as intracranial abscess. Infection with Cryptococcus, nocardia, candida, syphilis, and lymphoma. So all these are the causes of immunosuppression, and these are the immunocompromised patients in which the treatment should be given. And it's the important point to remember, the immunocompromised patients usually they get infections with the organism that usually do not cause infection in the patients who have normal immune system, and their immune system can fight against these different microorganisms. So they are even prone to infections to which the normal person is not susceptible. So immunocompromised patient needs more aggressive therapy and more aggressive treatment. So that concludes our lecture of chronic meningitis, in which we tried to cover all the important infectious causes and the non-infectious causes of chronic meningitis, how we can diagnose those conditions, and then we in detail look for the different diagnostic features associated with all those individual conditions. So thank you for watching sqadia.com.